This is a 36-year-old male with no past medical history, has fever, chills, worsening shortness of breath when laying down, and sharp stabbing chest pain. So not your normal cardiac patient. So what does this guy have? So this patient has pericarditis, which is inflammation of the pericardium. Pretty simple, right? And it's an inflammatory response and a specific cytokines. Remember, the pericardium is the membrane surrounding the heart. There's different kind of stages. We'll call it acute, resolving with 4 to 6 weeks, recurrent, which is relapsing after symptom-free interval for 4 to 6 weeks, incessant, greater than 4 to 6 weeks, but less than 3 months, and chronic greater than 3 months. Approximately 15 to 30% of patients experience recurrence after initial episode. So let's talk about the diagnosis. And we'll go through these several times. It requires 2 out of the 4 criteria. Typical chest pain for pericarditis, sharp, paralytic, improved with sitting up and leaning forward. You have a pericardial friction rub, high-pitched, scratchy sound heard with stethoscope. Very hard to hear. I've only heard it a couple times, but I have to use the very special stethoscopes that are amplifying the sound. ST segment elevation. You have EKG changes with new widespread ST elevation or PR depression. When you first look at these, you think the patient's having an MI, but then you see it going across all, and we'll show you an example of this, every one of the leads. So when you first see it, you're like, oh, this patient's having an MI. Let's go back to the pericardial friction rub. It's very hard to hear when you're in an emergency department, a busy room. It needs to be a quiet room with a very good electronic stethoscope. And then 4 is a new pericardial effusion, new or worsening fluid accumulation around the heart. See, when you see this example, you can see this ST elevation here, and it's here, and it's here. When you first look at these, it's everywhere. It's everywhere. When you first look at it, you think the patient's having an MI. All right, let's go through the diagnosis. You need to have at least 2 of the following signs and symptoms. Sharp paralytic chest pain that radiates to the trapezius ridge and relieved by sitting forward. Very important. That's typical for pericarditis. Positive pericardial friction rub. Hard to hear. Remember, you need to be in a quiet room to hear it. ST elevation in all leads except AVR and V1. PR segment depression. T wave inversion occurring after a few days. Pericardial effusion on echo. And this represents about 2/3 of patients. If diagnosis uncertain, obtain cardiac CT or MRI, you'll have pericardial or enhanced pericardial gadolinium uptake. So the GAD is meaning that there's inflammation. That's why you're having increased GAD uptake or contrast. We're going to do it one more time and kind of lock it in. Remember, at least 2 of the following. Sharp paralytic chest pain that radiates to the trapezius ridge, relieved by sitting forward. Positive pericardial friction rub. There's an audible rub. Hard to hear. I know people say it's really easy to hear. It's not. In the real world, can't do it in ER unless you have really good stethoscope and you can manage it well. EKG changes, ST changes in all leads except AVR and V1, and you'll have a PR depression. T-wave inversion after a few days. It looks like you had an MI when you initially look at it. Pericardial effusion on echo, and it's about 2/3 of patients. If uncertain, get a cardiac CT or MRI. You're going to have pericardial thickening, and you have enhanced gadolinium uptake. What are some poor prognostic factors? Acute factors would be a temperature greater than equal to 38 degrees Celsius. It means you're having this strong inflammatory response. Tamponade, trauma, if the patient's on anticoagulants. If the patient is immunocompromised, if they're immunocompromised. If they have an increased troponin, you're looking at myopericarditis, where the muscle's infected too. Below the pericardium, the muscle is also affected. And you have a large effusion, and it's greater than 20 millimeters. Large effusion greater than 20 millimeters. Recurring bouts of acute pericarditis over 2 to 5 years can be in up to 30% of the patients. So what's the treatment? The initial phase, aspirin or NSAIDs, ibuprofen and indomethacin can be used for NSAIDs, plus colchicine. It helps for rapid improvement and reduces reoccurrence. Now there's specific scenarios. Post-MI period, you'll need to have aspirin plus colchicine. You need the aspirin in the post-MI. If there's no response or the patient has connective tissue disease, steroids add if needed. Duration and tapering. NSAIDs 1 to 2 weeks, and then 3 months for colchicine, moderate doses, and then gradual tapering. Now let's talk about the algorithm of recurrent treatment in pericarditis. Recurrent pericarditis, restart insulin and colchicine used for about 6 months. Now this recurrence rate, you can get different numbers, but we'll say 15 to 30%, 20 to 30%. Colchicine offers the best prophylaxis. Steroids increase the risk for reoccurrence. Poor response on NSAIDs, you use steroids. If refractory cases, in refractory, colchicine can be added. Corticosteroids only used in refractory cases, recurrent or autoimmune pericarditis, and it's prednisone 60 milligrams q day and a taper 5 milligrams q3 days until 20 milligrams dose reached. Now, these doses are super high. Just so you know, for aspirin, 650 milligrams q6, 4 to 6 hours. 4 to 6 hours for 3 to 4 weeks. Those are huge doses. You're definitely going to need to consider a PPI because there's going to be some gastric distress, especially with adding a prednisone. And then ibuprofen is going to be 400 to 800 milligrams q6 to 8 hours. Those are we call those ranger doses in the military. Those are huge doses. Those are ranger candy at a high dose for 6 to 8 hours, every 6 to 8 hours for 3 to 4 weeks. So you're going to have some gastric distress on this.